Chronic abdominal pain. Joseph C. Yars, Lawrence S. Friedman. 12. Evaluating any patient with a complaint of abdominal pain is challenging. Abdominal pain can be benign and self-limited or a harbinger of a serious life-threatening disease. See Chapter 11. Chronic abdominal pain poses a particularly challenging clinical problem. Not only is the management of chronic abdominal pain a frequently daunting task, but the clinician must also remain vigilant to avoid overlooking an otherwise specifically treatable structural, organic, disorder. Many disorders discussed in this chapter and elsewhere in this textbook can produce chronic or recurrent abdominal pain, Box 12.1. Many of these diagnoses require careful consideration and clinical interrogation in addition to appropriate diagnostic testing to discern whether the entity is indeed the cause of the patient's pain. Diagnosis of a functional GI disorder, FGID, is generally considered once potential causes of organic chronic abdominal pain have been confidently excluded. Although the causes of chronic abdominal pain are varied, the pathophysiologic pathways that produce chronic pain are common to many of them. This chapter focuses on the neuromuscular causes of chronic abdominal pain, centrally mediated abdominal pain syndrome, CAPS, and narcotic bowel syndrome, NBS. CAPS serves as a prototypical disorder that illustrates many of the complex and interrelated issues involved in caring for patients with chronic abdominal pain. Definition and clinical approach. Abdominal pain is considered chronic when it has been occurring constantly or intermittently for at least 6 months, acute when it has been occurring for no more than several days, and subacute when it has been occurring for more than several days but less than 6 months. These arbitrary definitions are often helpful when formulating a list of diagnostic considerations. The clinician initially must adopt a broad-based approach, which subsequently becomes more focused as the evaluation ensues. Importantly, although typical patterns of presentation are useful to remember, some patients, especially immunosuppressed and older persons, may present with atypical features. As in acute abdominal pain, see Chapter 11, the initial step in evaluating a patient with chronic abdominal pain is to elicit a detailed history. The chronology of the pain, including its abruptness of onset and duration, its location, and possible radiation should be determined. Visceral pain emanating from the digestive tract is perceived in the midline, given the relatively symmetrical bilateral innervation of the organs, but is diffuse and poorly localized. 1. Referred pain is ordinarily located in the cutaneous dermatomes that share the same spinal cord level as the affected visceral inputs. 2. The patient should be questioned about the intensity and character of the pain, with the understanding that these parameters are subjective. The patient's perception of precipitating, exacerbating, or mitigating factors may be useful when diagnostic possibilities are considered. When initially attempting to determine whether the patient's pain is due to an organic or functional process, the clinician should search for clues in the history and physical examination that support or refute the diagnosis of a progressive, chronic underlying illness. Features in the history that suggest an organic process include fever, night sweats, appetite change, weight loss, and nocturnal awakening. A complete physical examination is indicated to search for evidence of a systemic disease. The abdominal examination should employ a combination of inspection, auscultation, percussion, and palpation. In a patient with an acute exacerbation of chronic abdominal pain, the most critical step is to ascertain whether a process mandating immediate surgical intervention is present. See Chapter 11. Although most causes of chronic abdominal pain do not require immediate surgical treatment, a complication related to a disease process ordinarily associated with chronic abdominal pain may present acutely, e.g., intestinal perforation in a patient with IBD. Furthermore, a patient who has experienced chronic abdominal pain may present with acute pain related to another disease process, e.g., acute mesenteric ischemia in a patient with underlying IBS. The abdomen should be auscultated to detect an abdominal bruit, which may suggest chronic mesenteric ischemia. Abdominal palpation for the presence of organomegaly, masses, and ascites and examination for hernias are particularly pertinent. Other physical findings that suggest an underlying organic illness include signs of malnutrition, e.g., sarcopenia, edema, vitamin deficiencies, or extra-intestinal processes, e.g., arthropathy, cutaneous changes. Although not entirely specific, the closed eye sign is often seen in patients with CAPS, see later. Similarly, Carnet's sign and the hover sign, described later, may be seen in persons with pain emanating from the abdominal wall. Laboratory studies can be helpful, but the clinician must first distill pertinent facets of the history and physical examination to focus the laboratory assessment. Injudicious use of laboratory testing is costly, can confuse the clinical picture, and may even lead to complications. It is worth emphasizing that an abnormal laboratory test result does not necessarily prove causality in relation to a patient's pain syndrome. The clinician must exercise the utmost discretion when ordering and interpreting laboratory test results. Endoscopic and imaging studies have important roles in diagnosing and excluding many causes of chronic abdominal pain. Upper endoscopy, colonoscopy, capsule endoscopy, and EUS may be indicated in selected cases. Available imaging investigations include barium and radionuclide studies, US, CT, MRI, PET, and angiography, CT, MR, and conventional. The indications for each of these radiologic investigations differ, as do their potentials for clarifying an individual clinical situation. Endoscopic and radiologic testing in specific disorders is discussed in detail elsewhere in this textbook. Abdominal wall pain, anterior cutaneous nerve entrapment, and myofascial pain syndromes. An estimated 10% to 30% of patients presenting to a gastroenterologist with a complaint of chronic abdominal pain have chronic abdominal wall pain, CAWP, as a cause of their symptoms. Anterior cutaneous nerve entrapment syndrome, ACNES, and myofascial pain syndrome, MFPS, are common causes of CAWP. These syndromes share clinical, diagnostic, and treatment characteristics. The importance of recognizing them rests in providing the patient with an accurate diagnosis and effective treatment, as well as avoiding further expensive investigation and unnecessary surgical intervention. The abdominal wall should be suspected as the cause of symptoms when there is a complaint of chronic and unremitting abdominal pain that is unrelated to eating or bowel function but clearly related to movement. Patients with CAWP are often overweight, and the disorder is more common in women than men. Although ACNES was initially described in the 1970s, it remains a frequently under-recognized, overlooked, and misdiagnosed cause of chronic abdominal pain. 3-5 In ACNES, the pain is believed to occur when there is entrapment of a cutaneous branch of a sensory nerve that is derived from a neurovascular bundle emanating from spinal levels T7 to T12. The nerve entrapment may be related to pressure from an intra- or extra-abdominal lesion or to another localized process such as fat, fibrosis, or edema. Pain emanating from the abdominal wall is discrete and localized, in contrast to pain originating from an intra-abdominal source, which is diffuse and poorly localized. Anatomic considerations and mechanisms of nerve entrapment have been detailed elsewhere. 6.7 Patients usually point to the location of their pain with one finger, and the examiner can often localize the area of maximal tenderness to a region less than 2 cm in diameter. During physical examination, the patient often guards the affected area from the examiner's hands. Hover sign. 8 Patients often note that activities associated with tightening of the abdominal musculature result in an exacerbation of pain, and during physical examination, the clinician will note increased localized tenderness to palpation when the patient tenses the abdominal muscles. Carnot sign. 9 In MFPS, pain emanates from myofascial trigger points in skeletal muscle. Causative factors include musculoskeletal trauma, vertebral column disease, intervertebral disc disease, osteoarthritis, overuse, psychological distress, and relative immobility. The exact pathophysiology of pain in MFPS remains unclear. CAWP may occur in patients with MFPS. Pain may be referred from another site, and identification of trigger points is a useful physical finding. When attempting to identify a trigger point, the examiner uses a single finger to palpate a tender area. This is most often located in the central portion of a muscle belly, which may feel indurated or taut to palpation, and elicits a jump sign. 10 This finding refers to a patient's response by wincing, jerking away, or crying out as the myofascial trigger point is detected. Less commonly, Trigger points may be located at sites like the xiphoid process, costochondral junctions, or ligamentous and tendinous insertions. Successful treatment of acnes and MFPS not only improves symptoms, but also confirms the diagnosis. 11. 12 Box 121 Differential diagnosis of chronic or recurrent abdominal pain. Structural, or organic, disorders. Inflammatory appendicitis, Chapter 120, Celiac disease and gluten sensitivity, Chapter 107, Diverticular disease, Chapter 121, Eosinophilic gastroenteritis, Chapter 30, Epiploic appendicitis IBD, Chapters 115 and 116, Pelvic inflammatory diseases PSC, Chapter 68, Sclerosing mesenteritis, Chapter 39, Vascular celiac artery syndrome, Chapter 38, Mesenteric ischemia, Chapter 118, Superior mesenteric artery syndrome, Chapter 15, Metabolic diabetic neuropathy lead poisoning porphyria, Chapter 77, Neuromuscular anterior cutaneous nerve entrapment syndrome myofascial pain syndrome slipping rib syndrome thoracic nerve radiculopathy other abdominal adhesions, Chapter 123, Abdominal migraine, Chapter 15, Abdominal neoplasms, Chapters 32 to 34, 48, 54, 60, 69. 96, 125 to 127, Anaphylaxis, Chapter 10, Angioedema, Chapter 11, Cannabinoid hyperemesis syndrome, Chapter 15, Chronic pancreatitis, Chapter 59, Cyclic vomiting syndrome, Chapter 15, Ehlers-Danlos syndrome endometriosis, Chapter 128, Familial Mediterranean fever, Chapter 37, Gallstones, Chapter 65, Hernias, Chapter 27, Intestinal malrotation, Chapter 98, Intestinal obstruction, Chapter 123, Lactose intolerance, Chapter 104, Neurogenic abdominal pain, Abdominal migraine, Abdominal epilepsy, Chapters 15 and 37, PUD, Chapter 53, Small intestinal and pelvic lipomatoses, Chapter 39, Functional GI disorders biliary pain, gallbladder or SOD, Chapter 63, Centrally mediated abdominal pain syndrome functional, non-ulcer, dyspepsia, Chapter 14, Gastroparesis, Chapter 50, IBS, Chapter 122, Levator-Ani syndrome, Chapter 129, Narcotic bowel syndrome/opioid-induced GI hyperalgesia 160 Part 3 Symptoms, Signs, and biopsychosocial issues treatment. Strategy depends on the symptom severity. With mild and intermittent symptoms that are reproducibly precipitated by certain movements, simple reassurance and a recommendation to avoid such movements may suffice. Non-narcotic analgesics, NSAIDs, and heat applications can be used during exacerbations. Physical therapy may be beneficial, although no randomized studies have supported this approach. For severe and persistent symptoms, injection therapy with a local anesthetic, with or without a glucocorticoid, is recommended. 11-13 Various techniques of injection have been described. 6 A retrospective survey-based study with follow-up of 6 to 12 months revealed that ultrasound-guided trigger point injection with an anesthetic plus a glucocorticoid resulted in significant symptom improvement in over one-third of patients. 14 Not unexpectedly, somatization was inversely related to treatment success. In a study of 136 patients in whom the history and physical examination suggested abdominal wall pain, and in whom benefit was noted with injection therapy, the diagnosis remained unchanged in 97% of cases after a mean follow-up of 4 years. 15 In carefully selected patients with symptoms refractory to injection therapy, a prospective non-randomized investigation suggested that diagnostic laparoscopy with open exploration of abdominal trigger points may be beneficial. 16 In this study, after intra-abdominal adhesions in close proximity to a trigger point were lysed, subcutaneous nerve resection was performed. After a median postoperative follow-up of 37 months, an impressive 23 of 24 patients, 96%, believed that this approach was beneficial in managing their previously intractable pain. A retrospective observational STUDY-17 and a double-blind, randomized, controlled trial from the same investigators 18 also showed long-term benefit from anterior neurectomy in patients with symptoms refractory to more conservative therapy. Slipping rib syndrome. The slipping rib syndrome, SRS, initially described in the early 20th century 1920, is an uncommonly recognized cause of chronic lower chest and upper abdominal pain. SRS ordinarily causes unilateral sharp, often lancinating pain in the subcostal region. The acute pain may be followed by a more protracted aching sensation. The syndrome is associated with hypermobility of the costal cartilage at the anterior end of a false rib, rib 8, 9, or 10, with slipping of the affected rib behind the superior adjacent rib during contraction of the abdominal musculature. This slipping causes pain by a variety of potential mechanisms, including costal nerve impingement and localized tissue inflammation. The key to diagnosis is clinical awareness of the syndrome. In conjunction with use of the hooking maneuver, the clinician hooks the examining fingers underneath the patient's lowest rib, and as the rib is moved anteriorly the pain is reproduced and an audible pop or click is often heard. 21 Conservative therapeutic measures often suffice, but costochondral nerve blockade, response to which supports the diagnosis, or even rib or costal cartilage excision are occasionally required. 22, 23. In persons with thoracic hyperkyphosis and kyphoscoliosis, rib tip syndrome, costoiliac impingement, may cause pain in a manner resembling that of SRS. The condition is often treated successfully with weighted kyphoorthosis, a specifically weighted back support device that centers the body over the legs, and back strengthening. 24 Thoracic nerve radiculopathy disease related to thoracic nerve roots T7 through T12 may be responsible for abdominal pain. The disease processes that may cause this problem include neuropathy related to back and spine disorders, diabetes mellitus, and herpes zoster infection. 25, 26 Obtaining a complete patient history and performing a careful physical examination, with attention to the possibility of a systemic disease and abnormal neurologic and dermatologic findings, should lead to the correct diagnosis. Treatment depends on the specific underlying disease process. Centrally mediated abdominal pain syndrome, formerly known as the functional abdominal pain syndrome, CAPS, is a distinct medical disorder. The name of this syndrome was changed from functional abdominal pain syndrome to CAPS to more accurately reflect its pathophysiology. The disorder is also called chronic idiopathic abdominal pain or chronic functional pain and is distinct from abdominal migraine, in which the pain is cyclical. See Chapter 15, Chronic pelvic pain, malingering, or feigned pain, see Chapter 23, IBS, see Chapter 122, and functional dyspepsia, FD, see Chapter 14. Evidence suggests that the syndrome relates to CNS amplification of normal regulatory visceral signals rather than functional, i.e., motility, abnormalities in the GI tract. 27 The disorder is characterized by continuous, almost continuous, or at least frequently recurrent, abdominal pain that is poorly related to bowel habits and eating. CAPS is properly understood as abnormal perception of normal, regulatory, bowel function rather than a motility disorder. The syndrome appears to be closely related to alterations in endogenous pain modulation systems, including dysfunction of descending and cortical pain modulation circuits. The Rome IV Consensus Committee diagnostic criteria for CAPS are shown in box. December 2, 28 studies that included patients who met diagnostic criteria for CAPS have revealed that only rarely is an organic cause of chronic abdominal pain found during long-term follow-up. 29, 30 CAPS is commonly associated with other unpleasant somatic symptoms, and when it persists or dominates the patient's life, it is usually associated with chronic pain behaviors and comorbid psychological disturbances. 31. Patients with CAPS typically define their illness as medical, and their symptoms tend to be more severe and associated with greater functional impairment than those of patients with IBS. Psychological disturbances, if present, must be considered as comorbid features of CAPS rather than box 122 Rome 4 diagnostic criteria. * For centrally mediated abdominal pain syndrome must include all the following: 1. Continuous or nearly continuous abdominal pain. 2. No or only occasional relationship of pain with physiological events, e.g., eating, defecation, menses. 3. Pain limits some aspect of daily functioning. 4. Pain is not feigned. 5. Pain is not explained by another structural or functional GI disorder or other medical condition. Asterisk criteria fulfilled for the past 3 months, with symptom onset at least 6 months prior to diagnosis. Centrally mediated abdominal pain syndrome is typically associated with psychosocial comorbidity, but there is no specific profile that can be used for diagnosis. Some degree of GI dysfunction may be present. Daily function could include impairments in work, intimacy, social/leisure, family life, and caregiving for self or others. From Horwell P.J., Kiefer L., Drossman D., ETAL centrally mediated disorders of gastrointestinal pain. In, Drossman D., Chong L., Che W.D., Kell Lo J., Tak J., Whitehead W., editors. Rome 4, Functional Gastrointestinal Disorders, Disorders of Gut-Brain Interaction. I. Raleigh, N.C., The Rome Foundation, 2016. pp. 1059-1116. Chapter 12 Chronic Abdominal Pain 161 12 Part of a primarily psychiatric problem. 32 When compared with patients who have chronic back pain, those with chronic abdominal pain report significantly better physical functioning, yet their overall perception of health is significantly worse. 33 Epidemiology. Although the epidemiology of CAPS is incompletely known, the disorder is believed to be less common than other FGIDs, with an estimated prevalence of 2%. 34 A female predominance is noted. FM equals 1.5. Patients with CAPS miss more workdays because of illness and have more physician visits than those without abdominal symptoms. A substantial proportion of patients are referred to gastroenterology practices and medical centers. They have a disproportionate number of healthcare visits and often undergo numerous diagnostic procedures and treatments. Pathophysiology. Chronic pain is a multidimensional, sensory, emotional, cognitive experience explained by abnormalities in neurophysiologic functioning at the afferent, spinal, and cerebral levels. Unlike acute pain arising from peripheral or visceral injury or disease, chronic functional pain is not associated with increased afferent visceral stimuli from structural abnormalities and tissue damage. CAPS is considered a biopsychosocial disorder related to dysfunction of the brain-gut axis with alterations in modulatory and motivational pain dimensions, central sensitization with disinhibition of pain signaling. See Chapter 22.28, 32 as shown in Fig 12.1. The clinical expression of CAPS is derived from psychological and intestinal physiologic input that interacts in a dynamic fashion via the CNS gut neuraxis. This model integrates the clinical, physiologic, and psychosocial features of CAPS into a comprehensible form, providing the basis for understanding psychological influences and application of psychopharmacologic treatments. Research relating to the pathophysiology of painful FGIDs has focused on the concepts of visceral hypersensitivity and alterations of brain-gut interactions. In CAPS, dysregulation of the brain-gut axis is manifested by central enhancement of afferent visceral signals, as opposed to visceral hypersensitivity. Point 28, 35 The brain-gut dysregulation in CAPS can be initiated or modified by a variety of events, including cognitive and emotional input. A prospective controlled investigation of the development of chronic abdominal pain in women undergoing gynecologic surgery for non-painful indications revealed that pain developed significantly more frequently in the surgical group. 36 Development of chronic abdominal pain in the postoperative setting was predicted only by psychosocial variables, implying that development of pain is closely associated with central registration and amplification of the afferent signal. This study lends strong support to the biopsychosocial model and the importance of cognitive and emotional input during development of postoperative CAPS. Ascending visceral pain transmission. Afferent transmission of visceral abdominal pain involves first-order neurons that innervate the viscera, carry information to the thoracolumbar sympathetic nervous system, and subsequently synapse in the dorsal horn of the spinal cord. Second-order neurons cross and ascend from the dorsal horn via the spinothalamic and spino-reticular tracts. These second-order neurons synapse in the thalamus with third-order neurons that synapse with the somatosensory cortex, sensory discriminative component, which is involved in the somatotypic or point-specific localization and intensity of afferent signals, and with the limbic system, motivational affective component, which contains the anterior cingulate cortex, ACC Fig 12.2, see also Chapter 22. The insular cortex receives input from the sensory thalamus and the nucleus tractus solitarius and integrates visceral sensory and CNS ends caps symptom experience behavior life stress psychologic state coping social support psychosocial factors genetics environment early life inflammation motility sensation physiology outcome medications health provider visits daily function quality of life Fig 12.1 biopsychosocial model of centrally mediated abdominal pain syndrome. CAPS. Consistent with a biopsychosocial model of illness, a person may be predisposed to CAPS because of factors, e.g., genetic, environmental, in early life. Symptoms and behavioral responses result from the interaction between psychosocial factors, e.g., life stress, social support, and GI physiology, i.e., inflammation, motility, and sensation. CAPS relates to dysfunction in the brain-gut neuraxis, with abnormal modulation of afferent signals from the intestine that influences the symptoms experienced, and leads to increased use of healthcare resources and reduced quality of life. ENS, enteric nervous system. MCC-ACC limbic system insula spinothalamic tract reticulothalamic tract thalamus primary somatosensory cortex spino-reticular tract Fig 12.2 neuroanatomic pathways that mediate visceral pain sensation. Afferent transmission of visceral abdominal pain involves first-order neurons that innervate the viscera and subsequently synapse in the dorsal horn of the spinal cord. Second-order neurons ascend from the dorsal horn of the spinal cord via the spinothalamic tract and the spino-reticular and reticulothalamic tracts to link in the thalamus with third-order neurons that then synapse in the limbic system, which contains the insula and anterior cingulate cortex, ACC, and in the primary somatosensory cortex. MCC, mid-cingulate cortex. 162 Part 3 Symptoms, Signs, and Biopsychosocial Issues Emotional Information. 37 The limbic system serves as a modulator of the pain experience, based on the individual's emotional state, prior experiences, and cognitive interpretation of the signal. This multi-component integration of nociceptive information in the CNS explains the variability in the experience and reporting of pain. 38 Motivational affective regions of the CNS are important contributors to the chronic pain experience by modulating afferent sensory information from the intestine. This conceptual scheme of pain modulation has been demonstrated through PET imaging. 39 In a group of healthy subjects who immersed their hands in hot water, half were hypnotized to experience the immersion as painful and the other half as not painful or even pleasant. No difference was found in activity in the somatosensory cortex, however, those who experienced pain had significantly greater activation of the ACC of the limbic system, the area involved in the affective component of the pain experience. Functional brain imaging studies comparing patients with functional GI disease and normal controls have shown abnormal brain activation in the motivational affective pain regions, including the prefrontal cortex, ACC, amygdala, and insula. 40 These regions show increased activation in patients with chronic pain, suggesting abnormal afferent input as well as central modulation, which could be caused in part by increased attention to visceral stimuli, abnormal cognitive or affective processing of afferent input, or comorbid psychiatric disorders. Descending modulation of pain. According to the gate control theory, afferent transmission of visceral pain can be modulated by descending impulses from the cortex down to the visceral nerves. 38 In this model, the central descending control of the gating system occurs primarily through the descending inhibitory system. 41 This system is an endorphin or enkephalin-based neural network that originates from the cortex and limbic system and descends to the spinal cord, with major links in the midbrain, periaqueductal gray, and medulla, caudal raphe nucleus. Fig 12.3. This system inhibits nociceptive projection directly on the second-order neurons or indirectly via inhibitory interneurons in the spinal cord. Then the dorsal horn of the spinal cord acts as a gate to modulate, i.e., increase or decrease, transmission of afferent impulses from peripheral nociceptive sites to the CNS. In effect, this descending pain modulation system determines the amount of peripheral afferent input from the GI tract that ascends to the brain. Descending inhibitory systems can be diffuse and, when activated, inhibit pain sensitivity throughout the body's so-called diffuse noxious inhibitory control. Patients with chronic pain syndromes, including CAPS, appear to have an impaired ability to activate diffuse noxious inhibitory control. 42-43 Visceral sensitization. Recurrent peripheral stimulation is thought to upregulate afferent signals or inhibit descending pain control mechanisms, thereby sensitizing the bowel and producing a state of visceral hyperalgesia, increased pain response to a noxious signal, and chronic pain. Clinical investigation has supported this concept, and the increase in pain appears to occur to a greater degree in patients with FGIDs than in healthy subjects. 44 Preoperative treatment with local or regional anesthesia or NSAIDs reduces the severity of postoperative pain. 45 Suggesting that the CNS response to peripheral injury can be modified by prior reduction of afferent input to the CNS. Conversely, recurrent peripheral injury, e.g., repeated abdominal operations, may sensitize intestinal receptors, thereby making perception of even baseline afferent activity more painful. Allodynia. Visceral sensitization may develop through different mechanisms at one or more levels of the neuraxis. Rectal hypersensitivity induced by repetitive painful rectal distension is seen in patients with IBS but not CAPS. 46 This observation supports the contention that IBS and CAPS are distinct disorders, with IBS being a disorder of enhanced afferent excitation and CAPS being a disorder characterized by alterations in descending pain modulation with preeminent central disinhibition. Biochemical role of 5-HT serotonin, 5-hydroxytryptamine. 5-HT, has received considerable attention because the GI tract is its main source within the body. 47 5-HT is found primarily in mucosal enterochromaffin cells, where it appears to serve as a neurotransmitter of the enteric nervous system and as a paracrine molecule that signals other, e.g., vagal, neural activity. 5-HT mediates numerous GI functions, and modulation of various receptor subtypes, e.g., 5-HT1, 5-HT3, 5-HT4, and 5-HT reuptake affects GI sensorimotor function. 5-HT is therefore an important modulator of the brain-gut neuraxis, and its dysregulation appears to play an important role in central pain amplification. 48 Pharmacologic manipulation of the serotonin system is an appealing target for therapy. Role of the CNS. Although peripheral sensitization may influence the onset of pain, the CNS is critically involved in the predisposition to and perpetuation of chronic pain due to central disinhibition. In CAPS, the preeminent role of the CNS is evident by the lack of peripheral motor or sensory abnormalities and the strong association with psychosocial disturbances. In addition, comorbid psychiatric diagnoses, major life stressors, a history of sexual or physical abuse, poor social support, and maladaptive coping strategies are all associated with more severe chronic abdominal pain and poorer health outcomes. 49-50 These factors in patients with CAPS and other functional GI pain conditions may impair or diminish descending inhibitory pain pathways that act on dorsal horn neurons or may amplify visceral afferent signals. 32-42 51 ACC amygdala. Limbic system. Rostral ventral medulla. Opioidergic pathway, serotonergic pathway, noradrenergic pathway, locus coeruleus, pag thalamus, caudal raphe nucleus. Fig 12.3 Descending endorphin or enkephalin mediated inhibitory system. This network includes connections from the sensory cortex and limbic system, via amygdala and thalamus, which have major links to the midbrain periaqueductal gray, PAG, matter, locus coeruleus, and medullary caudal raphe nucleus. Connections then project to neurons in the dorsal horn of the spinal cord. When activated, this system inhibits afferent impulses from peripheral nociceptive sites, e.g., colon, to the brain. Endorphin activity, which has opioidergic properties, is facilitated by release of serotonin, serotonergic pathway, and possibly norepinephrine, noradrenergic pathway. ACC, Anterior cingulate cortex. Chapter 12 Chronic Abdominal Pain 163 12A study in 31 healthy volunteers utilized functional brain MRI to show that higher neuroticism scores are associated with engagement of brain regions responsible for emotional and cognitive appraisal during the anticipation of pain. 52 This finding supports a maladaptive mechanism of overarousal with the anticipation of pain and a consequent lack of ability to cope during a painful experience in persons with higher neuroticism scores. Prospective studies of patients with post-infection IBS, see Chapter 122, and postoperative CAPS also support the importance of the brain in the experience of GI pain. 36, 53 The relation of the fecal microbiota to the brain-gut neuraxis and CAPS is under study. 54 Functional brain imaging has been useful in clarifying brain-gut interaction and has demonstrated that links between cognitive and emotional mechanisms and the chronic pain experience may be mediated through impairment in the ability of the limbic system to appropriately modulate visceral signals. The motivational affective component of the CNS, specifically the ACC, see Figs 12.2 and 12.3, is dysfunctional in patients with FGIDs, e.g., IBS, and other chronic painful conditions. 55-57 A study of patients with IBS and an abuse history used functional brain MRI to show that during aversive visceral stimulation, rectal balloon distension, differential activation of regions of the ACC occurred. 58 This study confirmed a strong association between visceral pain reporting and brain activation in predetermined brain regions involved in the affective and motivational aspects of the pain experience. Return to baseline of ACC activity in depressed patients is associated with clinical improvement. 59 and predicts response to antidepressant treatment. 60 As the pain and emotional distress of a patient with IBS improved, the activity within the ACC changed correspondingly. 59 Additional research has revealed that in FD, cerebral glucose metabolism is increased even in the resting state in CNS areas believed to be important in functional bowel disorders. 61 The observed synergistic effect of IBS and abuse history on differential ACC activation suggests a mechanism to explain how afferent processing in the CNS can be associated with reporting of greater pain severity and poorer outcomes in this patient population. This and other research 62-66 has suggested that dysregulation of central pain modulation is critical and may occur in various medical and psychological conditions. One investigation used functional MRI to show that, when compared with normal controls and those with UC in remission, patients with IBS fail to effectively engage neural downregulation of pain induced by rectal distension during placebo analgesia administration. 67 The role of the endocannabinoid system in the brain-gut neuraxis and potential therapeutic implications have also been explored. 68 The challenge remains to reverse the findings on functional brain imaging studies by a multifaceted approach, with a concomitant improvement in patient outcomes. The presence of structural brain changes in CAPS and other functional pain disorders remains unproven, but the potential for neuroplasticity raises the possibility of reversibility if such changes exist. 28 Clinical implications The concept of CAPS as a dysregulation of brain-gut neuraxis function at various levels has important clinical implications. By linking psychosocial factors to the pathophysiology of chronic abdominal pain, this conceptual scheme transforms the therapeutic approach from a purely psychiatric one to a paradigm that encompasses a broader array of potential therapies. Early pharmacologic and psychological treatment ultimately may be shown to reverse the dysregulated modulation of sensory input and structural brain changes that are associated with chronic pain. 69 Thereby preventing development of a subsequent chronic pain syndrome. 70, 71 Clinical features History Typically, patients with CAPS are middle-aged and female. The history is one of chronic abdominal pain, often for more than 10 years, and the patient is often in distress at the time of initial consultation. The pain is frequently described as severe, constant, and diffuse. Pain is often a focal point in the patient's life, may be described in emotional or bizarre terms, and is not influenced by eating, defecation, or menses. The abdominal pain may be one of several painful symptoms or part of a continuum of painful experiences often beginning in childhood and recurring over time. 29 CAPS sometimes coexists with other disorders, and the clinician must determine the degree to which one of these other conditions contributes to CAPS. Frequently, CAPS will evolve in a patient who has had another well-defined GI disorder but has been operated on one or more times and developed chronic abdominal pain following these operations. Repetitive surgery in such patients is often performed for alleged intestinal obstruction caused by adhesions. Patients with CAPS often have a psychiatric diagnosis of anxiety, depression, somatization, or post-traumatic stress disorder. There may be a history of trauma, including military trauma. A history of sexual and physical abuse is frequent and is predictive of poor health, refractoriness to medical care, and a high number of diagnostic and therapeutic procedures and healthcare visits. 50 Possibly having learned in childhood that attention is more likely received when reporting physical illness but not emotional distress, patients may minimize the role of psychological factors. A history of unresolved losses is a common feature. 72 Because patients do not usually volunteer an abuse history, physicians should inquire in this regard. 73 Finally, patients with CAPS may report poor social networks and exhibit ineffective coping strategies. They feel unable to decrease their symptoms, may be unable to identify and express emotions, alexithymia, and may catastrophize, i.e., view their condition in pessimistic and morbid ways without any sense of control over the consequences. Chronic abdominal pain may be an independent risk factor for suicidal ideation. 28 These cognitions are associated with greater pain scores that lead to a cycle of more illness reporting, more psychological distress, and poorer clinical outcomes. 74 For many, the illness provides social support via increased attention from friends, family, and healthcare providers. Patient behavior. Certain behavioral traits are common in patients with CAPS. These patients often demand that the physician diagnose the problem promptly and relieve their chronic symptoms rapidly. They similarly deny a relationship between their problem and psychologically disturbing issues and often attribute depression to pain rather than recognizing it as a contributing factor. Frequently, an accompanying spouse or parent takes responsibility for reporting the patient's history, an observation that suggests the possibility of family dysfunction. A history of narcotic use is not uncommon, see later, as is a request by the patient for such medication during the initial visit. This type of behavior reflects the patient's consideration of his or her situation as an acute condition requiring immediate symptom relief, rather than a chronic condition in which treatment must be directed toward enhancing coping and adaptive strategies. Physical examination. Certain physical findings help support a diagnosis of CAPS. Abdominal palpation should begin at an area remote from the perceived site of maximal intensity. The patient's behavior. 164 Part 3 Symptoms, signs, and biopsychosocial issues during abdominal palpation should be noted, with an emphasis on whether a change is noted during distracting maneuvers. Patients with CAPS usually lack signs of autonomic arousal. The presence of multiple abdominal surgical scars without clearly understood indications may suggest chronic pain behaviors that have led to unnecessary procedures. The closed eye sign may be NOTED75. When the abdomen is palpated, the patient with CAPS may wince, with closed eyes, whereas those with acute pain due to organic pathology tend to keep their eyes open in fearful anticipation of the examination. Often, the stethoscope sign, gentle, distracting compression with the diaphragm of the stethoscope on a painful site of the abdomen, elicits a diminished behavioral response in a patient with CAPS, thereby affording a more accurate appraisal of the intensity of pain. Performing a thorough physical examination ensures that another diagnosis is not overlooked, e.g., pain emanating from the abdominal wall, and legitimizes the patient's pain as a medical condition. Diagnosis and differential diagnosis. After obtaining a complete history, performing a thorough physical examination, and paying appropriate attention to psychosocial factors in the patient's life, the scenario will often point the physician toward a diagnosis of CAPS. A physical examination that does not suggest evidence of organic intra-abdominal pathology, as well as normal results of routine laboratory tests, lends support to the contention that the patient's pain is not due to an identifiable structural disease. Recognition of the diagnostic criteria for CAPS, see box 12.2, and failure to find evidence of another cause of chronic abdominal pain, see box 12.1, should lead the physician to a diagnosis of CAPS. If the features of CAPS are absent or atypical, or if concerning abnormalities are found on physical examination, e.g., abdominal mass, enlarged liver, or on screening laboratory studies, e.g., anemia, hypoalbuminemia, another diagnosis should be considered and pursued accordingly. Not uncommonly, nonspecific abnormalities are found, e.g., a liver cyst, and require determination of their relevance to the patient's symptoms. A clinical algorithm for the diagnosis of CAPS has been proposed, Fig 12.4.27 treatment establishing a successful patient-physician relationship once other diagnoses have been excluded, formation of a successful relationship between the patient with CAPS and physician, or other healthcare provider, is critical for effective management. Several factors must be considered to help establish this relationship and move toward successful treatment. See Chapter 22. An understanding of the psychosocial background is helpful because a detailed knowledge of this aspect of the patient's life aids in selecting the most useful treatment strategies. Having an appreciation of the degree of the patient's understanding of the illness is important, particularly for enhancing the success of a treatment plan. Early in the development of the patient-physician relationship, it is important to determine whether there are abnormal illness behaviors and associated psychiatric diagnoses, which are present in up to 60% of patients with CAPS. 28 The role of the family in relation to the patient's illness should also be understood. Normally, family experiences with illness lead to emotional support and a focus on recovery. With dysfunctional family interactions, stresses are not managed in an optimal fashion, and diverting attention toward illness serves to reduce family distress. 76 Dysfunction is seen when family members indulge the patient, assume undue responsibility in the patient's management, or become the spokesperson for the patient. If such family dysfunction is observed, counseling may help the family develop more useful coping strategies. Cultural belief systems must also be understood because patients may not comply with treatments that are inconsistent with their cultural values. It is important to gain knowledge of the patient's psychosocial resources, i.e., the availability of social networks, that may assist in buffering the adverse effects of stress and improve the outcome. It is essential for the physician to convey validation of illness to the patient by non-judgmentally acknowledging the illness and the effect it has had on his or her life. This step is important to ensuring the patient understands that the physician considers CAPS to be a medical illness. Empathy is primary. It acknowledges the reality and distress associated with the patient's pain and can improve adherence to a treatment plan, patient satisfaction, and clinical outcomes. 77 It does not, however, equate with overreacting to the patient's wish for a rapid diagnosis and overmedication or performing unnecessary diagnostic studies. Education is provided by eliciting the patient's knowledge of the syndrome, addressing any concerns, explaining the nature of the symptoms, and ensuring understanding in all matters that have been discussed. It is helpful to reiterate that CAPS is a medical disorder and that symptoms can be attenuated by pharmacologic or psychological treatments that modify the central regulation of pain control. Reassurance should be provided because patients may fear serious disease. After the evaluation is complete, the physician should respond to the patient's concerns in Fig 12.4 Algorithm for the Diagnosis of Centrally Mediated Abdominal Pain Syndrome, CAPS. EPS, Epigastric Pain Syndrome, FGIDs, Functional GI Disorders. Adapted from Kiefer L., Drossman D., Guthrie E., ETAL Centrally Mediated Disorders of Gastrointestinal Pain. Gastroenterology 2016, 150:140819, with permission. Patient with continuous or nearly continuous abdominal pain for 3 months with onset at least 6 months ago. Manage appropriately. Yes, yes, no, 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 yes, yes. Pain is feigned or represents drug-seeking behavior. Referral to mental health care professional for evaluation. Suspicion that pain is feigned or represents drug-seeking behavior. Consider IBS, EPS, or other painful FGIDs, structural GI disease, or gynecologic disorders. Pain associated with bowel movements, eating, or menses. Alarm features identified on history or physical examination. Appropriate diagnostic evaluation for alarm features. CAPS. No pain is not associated with known systemic disease. Limitation of daily functioning, including work and socializing. Chapter 12 Chronic Abdominal Pain 165 12 A clear, objective, and non-dismissive manner. Both patient and physician must then negotiate the treatment. This approach will enable the patient to contribute to and take some responsibility for the treatment plan. Within the context of the patient's prior experience, interests, and understanding, the physician should provide choices rather than directives. Adherence to a treatment plan is more likely when the patient has confidence that it will benefit him or her and its rationale is understood. Finally, the physician must set reasonable limits in relation to time and effort expended and realistic expectations from treatment. The key to success is to maintain a trusting relationship while setting proper boundaries. Instituting a treatment plan. Once the diagnosis of CAPS has been made, the primary focus should move away from testing and evaluation and toward development of an effective multifaceted treatment plan that incorporates ongoing patient visits and pharmacological and behavioral treatments. The clinical scenario will necessarily dictate the specific approach, with the understanding that combination and augmentation strategies are often required. See later in Fig 12.5.27. It is paramount that the patient understands that the goal of therapy is to attenuate symptoms and facilitate adaptation to this chronic condition, as opposed to attaining a cure. The patient should increase his or her responsibility for the illness by identifying the circumstances surrounding episodes of pain, including emotional and cognitive responses. This technique helps the patient achieve insight into aggravating factors and characterizes the patient's coping style. Such information helps identify a strategy for behavioral treatment. In general, laparoscopy and lysis of adhesions is not recommended in patients with CAPS in the absence of evidence of intestinal obstruction except in carefully selected patients. 77 A pharmacotherapy. There is a paucity of evidence from prospective randomized controlled trials to support drug therapy in CAPS. Drug development in FGIDs, particularly CAPS, has been slow, in part because of the rather empirical process for experimental testing that necessarily occurs in a symptom-based syndrome. 78 Also, when compared with other FGIDs, e.g., IBS, FD, CAPS is less common. Pharmacologic brain imaging approaches hold promise as a vehicle to accelerate drug discovery and subsequent development. 79 Despite these limitations, some specific medications have been used successfully in an off-label fashion to treat CAPS. See later. 79 Quite predictably, peripherally acting analgesics, e.g., acetaminophen, aspirin, other NSAIDs, offer little benefit to patients with CAPS, given the pathophysiology of the disorder, i.e., a biopsychosocial disorder related to brain gut neuraxis dysregulation. Narcotics and benzodiazepines should not be prescribed for treatment of CAPS because of the potential for increased pain sensitivity and a lowering of the pain threshold, respectively. The omnipresent potential for drug dependency with these types of medications must also be borne in mind. Prescribing such medications subordinates development of more comprehensive treatment strategies to merely providing medication and can be counterproductive by leading to narcotic-induced potentiation of visceral pain, thus resulting in NBS. See later. 80 As in the treatment of other chronic pain disorders, tricyclic antidepressants, TCAS, can be helpful in CAPS. 81-83 Acting through inhibition of serotonin and norepinephrine reuptake, the benefit of these medications is derived from their ability to directly improve pain and, when utilized at higher doses, treat associated depression. 84 When the goal is to treat pain, TCAS can be given in doses lower than those used to treat major depression, e.g., desipramine, 25 to 100 mg/day at bedtime, to minimize side effects. However, dosage increases may be needed, particularly if the patient has psychiatric comorbidity. There is less evidence for the use of selective serotonin reuptake inhibitors, SSRIs, e.g., citalopram, in CAPS, because their lack of norepinephrine transporter inhibition compromises their ability to provide central analgesic effects. 85-86 SSRIs can, however, be used when anxiety-related symptoms are dominant. 84, 87 serotonin and norepinephrine reuptake inhibitors, SNRIs, e.g., duloxetine, venlafaxine, milnacipran, are beneficial in CAPS. 78, 84, 88, 89. These medications are less constipating than TCAS but more potent central analgesics than SSRIs. Like TCAS, SNRIs can be used to treat pain and depression simultaneously. 78, 90 atypical, second-generation, antipsychotics, e.g., quizapine, aripiprazole, other antidepressant or anti-anxiety agents, e.g., mirtazapine, buspirone, and delta ligand agents, e.g., pregabalin, gabapentin, have been used in combination with other agents, so-called augmentation therapy, when there is a suboptimal clinical response to a TCA or SNRI. 78, 84, 91. Pharmacologic augmentation therapy derives its benefit from the use of two agents, each usually at a lower dosage, that target different brain areas or receptors to achieve an optimal clinical response. 91. Given the potential for serious and complex adverse events, augmentation therapy utilizing two central neuromodulators should be prescribed by physicians or multidisciplinary groups with particular knowledge and experience in the use of such treatment. 27. A systematic review and meta-analysis of TCAS, SSRIs, SNRIs, and cognitive behavioral therapy, see later, in IBS has shown that all these treatments are effective. Number needed to treat equals 4. 92. Potential adverse events related to the use of central neuromodulators and precautions pertaining to discontinuation. Mental health interventions. Consider mental health referral, combination therapy, symptomatic medical treatment, stress reduction, education, exercise, meditation, yoga, etc. Patient-physician relationship. CBT 4 to 6 weeks * 4 to 6 weeks * mindfulness hypnotherapy * monitor side effects, severity of symptoms, low-dose TCA or SNRI, increased dose augmentation, 2 drugs, Fig 12.5. Overview of the management of centrally mediated abdominal pain syndrome based on the severity of symptoms. The cornerstone of treatment is the development of a strong physician-patient relationship and institution of a treatment plan that incorporates pharmacologic and behavioral approaches, beginning with medications directed at specific symptoms and lifestyle changes, e.g., stress reduction, exercise, and education. For chronic pain, a low-dose tricyclic antidepressant, TCA, or serotonin and norepinephrine reuptake inhibitor, SNRI, may be initiated. Augmentation therapy can occur with the addition of a second pharmacologic agent, see text. A mental health intervention, such as cognitive behavioral treatment, CBT, or hypnotherapy, may be considered to help manage pain and reduce psychological stress caused by symptoms. In severe cases, combination therapy with both a medication and a mental health intervention is appropriate. Adapted from Kiefer L., Drossman D., Guthrie E., et.al. Centrally mediated disorders of gastrointestinal pain. Gastroenterology 2016, 150:140819, with permission. 166. Part 3. Symptoms, signs, and biopsychosocial issues of these agents have been reviewed. 84. To enhance adherence with the use of central neuromodulators, the physician should explain that these medications work as central analgesics and are not simply being used to treat a psychiatric condition. Investing the time to explain that these drugs induce neurotransmitter changes in the brain and thereby alter pain perception, and that the dosage is usually lower, in the case of TCA therapy, than that typically chosen for treatment of psychiatric disorders, is often helpful. It is beneficial to emphasize that, while clinical benefit may lag by weeks, side effects occur early in the course of treatment. Especially with the use of TCAS, most side effects diminish after a few days and can be reduced by temporarily lowering the drug dose. Nevertheless, patients frequently report adverse effects and discontinue newly prescribed medications prematurely, even though symptoms attributed to a drug are often present before treatment. 93. Study of the variability of gene expression relevant to an individual's susceptibility to a disease and the subsequent drug response, i.e., pharmacogenomics, holds promise as a tool for optimizing the management of chronic pain syndromes in general and in FGIDs specifically. 94-96 Mental health. Referral and psychological treatments. Although augmentation therapy utilizing two pharmacological agents has been described above, another approach to augmentation is combination therapy with a pharmacological agent and a psychological treatment, see Fig. 12.5. The latter approach is theoretically appealing because psychological treatments work on higher cortical areas, whereas antidepressants target subcortical regions. 27. 97 Patients may be reluctant to see a mental health provider because they lack knowledge of the benefits of referral, feel stigmatized for being thought to have a psychiatric problem, or see referral as a rejection by the medical physician. Psychological interventions are best presented as vehicles that are orchestrated in parallel with medical visits and are used to help manage pain and reduce the psychological distress caused by the symptoms. The mental health provider may recommend any of several psychological treatments for pain management. 98. 99 These psychological treatments derive their benefit from facilitating enhancement of higher brain function, e.g., cognitive adaptation to prior trauma and improvement in coping strategies. Cognitive behavioral treatment, CBT, which identifies maladaptive thoughts, perceptions, and behaviors, is applicable to CAPS in a program that combines psychoeducation and skills training, e.g., relaxation techniques. 82 The evidence of benefit from CBT has been derived predominantly from study of patients with IBS. 92, 100, 101 Evidence from functional brain imaging suggests that this psychological intervention decreases activation from rectal stimulation in the central emotional regions, e.g., amygdala, ACC, frontal cortex, that are typically hyperactive in chronic pain. 102 CBT has been shown to be particularly helpful in the management of children with CAPS, and in one study, benefit was also derived from parental involvement in the treatment paradigm. 103, 104 Mindfulness-based stress reduction involves consciously attending to one's moment-to-moment experience. 105 Although not specifically studied in CAPS, this psychological construct, which is related to meditation, shows promise and has been shown to be of benefit in patients with IBS and other chronic pain syndromes. 106 Hypnotherapy, in which the focus is on relaxation of the intestine, has been investigated primarily in patients with IBS and found to be of benefit in that disorder. 107, 108 A randomized controlled trial in children that included 31 patients with CAPS concluded that hypnotherapy is superior to standard medical therapy in reducing pain at 1 year. 109 A follow-up study showed that after a mean duration of 4.8 years, hypnotherapy remained highly superior to conventional medical therapy, indicating that the beneficial effects of gut-directed hypnotherapy are durable. 110 In general, cognitive factors such as confidence in and a positive perception of treatment contribute greatly to patient satisfaction with various therapeutic modalities in patients with CAPS. 111 Narcotic bowel syndrome / opioid-induced gastrointestinal hyperalgesia. Narcotic administration commonly causes GI dysmotility, with consequent constipation, ileus, and delayed gastric emptying, a clinical scenario referred to as opioid bowel disorder or narcotic bowel. A less common occurrence is the narcotic bowel syndrome, or opioid-induced GI hyperalgesia, which is a distinct disorder characterized clinically by a paradoxical increase in abdominal pain associated with continuous or escalating doses of narcotics. Box 12.3. 80, 112 NBS is a disorder of pathological pain facilitation and is independent of the effects of opiates on intestinal secretion and motility. NBS has been recognized increasingly, at least in part as a consequence of more liberal prescribing of narcotic medication for non-malignant disorders. 113, 114 The frequency of NBS in a general chronic pain clinic has been estimated to be 6%. And the prevalence in a large epidemiologic study has been estimated to be 4%. 115, 116 A large case series has suggested that NBS is typically seen in well-educated young to middle-aged women who may have a variety of functional or structural GI disorders. 113 The syndrome may also be seen in postoperative patients. Associated symptoms may include nausea, vomiting, heartburn, constipation, and diarrhea. Associated diagnoses may include gastroparesis and intestinal pseudoobstruction. As in CAPS, patients often have associated anxiety or depression and seek medical care frequently, leading to high associated healthcare costs. As might be expected, these patients are often disabled, have drug-seeking behavior, and view their general health as being extremely poor. A variety of postulated mechanisms for the occurrence of NBS have been described. 117 Proposed mechanisms include opioid-induced glial cell, microglia and astrocyte activation. 118 Enhancement of pain signaling in the dorsal horn via G-coupled excitatory opioid receptors. 119 Facilitation of pain through activation of descending pathways in the medulla. 120 Activation of box 123 Rome 4 Diagnostic criteria for narcotic bowel syndrome / opioid-induced GI hyperalgesia must include all the following: 1. Chronic or frequently recurring abdominal pain * that is treated with acute high-dose or chronic narcotics. 2. The nature and intensity of the pain is not explained by a current or previous GI diagnosis. 3. 2 or more of the following: A. The pain worsens or incompletely resolves with continued or escalating doses of narcotics. B. There is marked worsening of pain when the narcotic dose wanes and improvement when narcotics are reinstituted, SOR and crash. C. There is a progression of the frequency, duration, and intensity of pain episodes. Pain must occur on most days. A patient may have a structural diagnosis, e.g., IBD, chronic pancreatitis, but the character or activity of the disease process is not sufficient to explain the pain. From Horwell P.J., Kiefer L., Drossman D., et.al. Centrally mediated disorders of gastrointestinal pain. In Drossman D., Chong L., Che W.D., Kell Lo J., Tak J., Whitehead W., editors. Rome 4, Functional Gastrointestinal Disorders, Disorders of Gut-Brain Interaction. I. Raleigh, N.C., The Rome Foundation, 2016. pp. 1059-1116. Chapter 12 Chronic Abdominal Pain 167 12 Pain Facilitatory Pathways Viaduct Spinal Cord N-methyl diaspartate Receptors 121 and Abnormalities of Central Pain Processing, as in CAPS. Caring for these patients presents a challenge and requires a strong physician-patient relationship and opioid detoxification. In a case series of 39 patients with well-characterized NBS, an opioid detoxification program was successfully completed in 90% of patients and was associated with a statistically significant 35% reduction in abdominal pain. 122 For patients who remained off narcotics at 3 months after detoxification, the abdominal pain score was 75% lower than the pre-treatment score. Unfortunately, by 3 months, nearly half the patients had returned to narcotic use. The reason for such a high recidivism rate despite pain relief remains unclear but may relate in part to the finding that there is often little change in medical management and prescribing practices even after substance abuse is diagnosed. 123.